Welcome back, everyone. And here it is, the session many of you look forward to most, our Ask the Experts panel, where ovarian cancer experts answer all of your most pressing questions. We have a terrific panel for you this year, and this session is presented by GSK. So our panel this year is Dr. Dineo Khabele, Dr. Kathleen Moore, and Dr. Elaine Yanow. Dr. Khabele is a professor and chair of the Department of Obstetrics and Gynecology at Washington University of Medicine in St. Louis. Dr. Moore is chair in developmental therapeutics and professor of gynecologic oncology at the University of Oklahoma Health Sciences Center. And Dr. Yanow is professor of obstetrics and gynecology and the section chief of gynecologic oncology at the University of Chicago. We are thrilled to have this distinguished group of physician scientists with us today to answer all of your questions. So this session will take place in two parts, so be sure to come back after the break for part 2. And we'd like to thank AstraZeneca for sponsoring part 2. Thank you for being here today, Drs. Khabele, Moore, and Yanow, and I will turn it over to you.
Hello, welcome to everybody for our Ask the Experts panel session. I'm Elaine Yanow, and I am a professor and section chief for gynecologic oncology at the University of Chicago Cancer Center. And I'm really pleased to be joined by Dr. Katie Moore and Dr. Dineo Khabele. Do you want to say just a couple of words about yourselves? And although everybody knows who you guys are.
Dr. Khabele, why don't you go first?
Hi, I'm Dineo Khabele. I'm professor and chair of obstetrics and gynecology at Washington University in St. Louis, and also a senior leader of the Siteman Cancer Center, gynecologic oncologist, and physician scientist.
And I'm Kathleen Moore. I am the associate director of clinical research and director of phase 1 drug development for the Stevenson Cancer Center in Oklahoma City.
Thanks so much. It's really a pleasure to have both of you here, and we're really excited to be doing this panel talk. This is incredibly important, and we're really pleased to be able to provide some of the information and look at some of the questions that people have sent in. The questions are really fantastic. So I know we're not going to be able to answer all of them, but hopefully we will be able to get to many of the areas of interest that you all have. So I thought that we'd start out first by talking a little bit about early detection and screening. As people had questions about what's new in the early detection area. Is there anything that has come up recently that's of particular importance? And are there biomarker studies, for instance, that are particularly important in the early detection and screening world?
Well, I'll start and just say that, we urgently need more research in this area, because clearly the largest trials to look at screening and early detection for ovarian cancer have not shown any difference with the current biomarker of CA-125 and transvaginal ultrasound in a large population. These studies were performed primarily in the United Kingdom and unfortunately didn't show any difference in overall survival. But that doesn't mean that we don't stop trying to find new markers. And there's lots of research going on to try to detect ovarian cancer early. But right now we don't have anything definitive. And that's a hard thing to hear and to say, but also to make sure people know the urgency of more research needed in this area.
Yeah, I mean, I can't argue with anything that was just said. I think that there's been promising research that I think is still ongoing. For example, looking at markers of TP53, which is a mutation we see commonly in the majority of ovarian cancers in sort of vaginal swabs, has been ongoing at certain centers. Not quite ready for public disclosure, but those are promising studies based on some retrospective work done from big registries in other countries. And so that may be, we'll see. We've been down this road before with trying to find a biomarker that we can detect in general population screening. But my antennas are up for that one to see kind of what the early clinical trials look like. And those are mainly being done on the West Coast. So I don't know if you guys have heard, maybe I've missed, but that has not been reported yet, I don't think.
I have not seen that
I
reported.
haven't
Yeah, I don't
seen
think
it.
so. I think it's still ongoing. So that's sort of one option that people are looking at. I think the other option is looking for markers in the blood other than CA-125, circulating tumor DNA. Those are interesting tests, probably not quite ready for prime time. We don't really know what we're looking for yet in the blood. And so probably early adoption could lead to missed calls and surgeries that are unnecessary, et cetera. So there is some sparkles of interest in these new technologies out there, I would say, but you know, the studies to validate them are huge and they take years to do. So it's kind of a frustrating pace of development, I can acknowledge, for patients. I mean, it's just frustrating. Probably the best thing, if we could ever get it approved, is just to let everyone get at least tested for germline mutations that predispose to breast and ovarian cancer. And just if you want to know, you could know at a certain age. And if you have it, you find out early, and we can at least do risk reducing surgeries or other sorts of interventions. There's now vaccine studies that are going on at like Vassar Center at Penn, have a robust prevention program for women who are at high risk for breast and ovarian cancer. So they have those genetic mutations, but don't want surgery. They have some really interesting studies, clinical trials, not ready for prime time, but you can participate. Those sorts of things may be transformational. So if we could identify everyone who's at risk, then that would be outstanding. But the equity associated with being able to access those tests is far from there. So it's a troublesome situation we're in.
And to your point, Katie, I mean, you're talking about kind of universal testing for patients. I mean, I think, you know, we need to reiterate, and obviously everybody knows this, that patients that are diagnosed with ovarian or fallopian tube cancer all should undergo genetic testing. I think that we certainly have not done as well as we would like to in terms of getting all patients that are identified in for genetic testing. One of the questions that I wanted to ask you both was whether there are tools or tricks that you all have used at your institutions to try and enhance that uptake of testing that we could learn from or think about.
Well, I mean, at our institution, for right or wrong, and I want to emphasize, I think genetic counselors are gold. They are worth their weight in gold, and they provide far better counseling regarding genetic testing than I could ever hope to. But I'm not required to have my patients seen by genetic counseling before I order a test. I mean, that's sort of where the delay comes into play. I can just order all the tests. So, and it's very uncommon, you know, I do counsel my patients, very uncommon. I have patients that do not want to be tested. Every once in a while they don't, and that's okay. That's your choice, but I'm going to offer it to you. And then we send to genetic counseling. In an ideal world, it would be the reverse, but there's not enough of them. And that delay, once you start chemotherapy and all the things and you get busy and you're so engulfed in the treatment, we find that it gets forgotten. It falls through the cracks, and then you have a big missed opportunity to do what we call cascade testing if you are positive for relatives. If we were doing that, there's statistical, it was published out of MD Anderson a number of years ago now as part of the initial moonshot, but they basically demonstrated that if we were perfect at this, we tested every patient and we did cascade testing on their relatives, we could reduce the rate, the incidence of new ovarian cancer by 20% right off the top. If we were perfect at it. And then they had statistics for reduction in triple negative breast as well, that I can't quite remember. So, I mean, I think that's our minimum goal. But I would like to know, honestly, I would rather not have a relative get ovarian cancer before I could test all the family. I just really am a big proponent of it's part of screening, and it's not that expensive anymore. I don't know why we just don't offer it to everyone.
Yeah, I mean, I think that there's an important role in directly communicating with patients and families. We are using strategies with videos and a lot of educational content that we provide patients and their families directly to encourage this cascade testing. Because to your point, there may be some interventions like oral contraceptive pills that patients, family members can take to reduce the risk of developing ovarian cancer. It doesn't prevent it entirely, but reduces the risk. of developing ovarian cancer if a person takes oral contraceptives, and then we can decide and go through the shared decision making when we can perform the risk reducing removal of fallopian tubes and ovaries. And then there's several studies that are ongoing to look at whether we can sort of time these risk reducing surgeries and perhaps remove the fallopian tubes first, because that is the putative precursor for ovarian cancer, the most common types of ovarian cancer, and then not put young women into menopause if we don't have to. And so there's a lot of work that's going on in that area. A lot of our institutions are participating in these early studies. And then I want to circle back to the types of research ongoing for potential early detection, which would include liquid biopsies. Could you imagine if we had some sort of test where you perhaps didn't need to draw blood, but it could be something in a vaginal swab or urine or saliva that could then detect protein markers that would let us know that something was going on? Again, which proteins we're looking for, which are the markers, that's a huge area of research.
Right.
Absolutely. No, I think that's great. And that, one last thing just to highlight is the fact that with increased knowledge about the mutations that put people at risk, the guidelines for screening and for recommending risk reducing surgery and the age at which that should happen is changing is changing. So keeping up to date on that so that you can adequately counsel your patients, I think is certainly important. I'm thinking about recommendations around like RAD51C and D, for instance. So I think that's fantastic. So kind of moving on to some of the surgery and initial treatment questions that people proposed. There was one question around the correlation between staging, for instance, and recurrence, like whether there are certain molecular types that are at increased risk for recurrence, certain blood types, for instance, what correlates with increased risk of recurrence when it comes to ovarian or fallopian tube cancer?
Well, the biggest correlation from a surgical standpoint is whether you were able to remove all visible residual disease. And I think that that's the most important point. The ability to do that may be correlated with the underlying molecular biology of the tumors, and that's something that we're all studying and trying to figure out better predictive markers of being able to really remove all visible tumor. And these types of surgery are really big surgeries. I mean, even some of the surgeries that we do after neoadjuvant chemotherapy, I mean, there are risks to these surgeries, and we want to make sure that we are able to remove all visible tumor. So I think that I try to emphasize that that's the most important marker that we have to date as to whether a person is going to respond to chemotherapy and reduce the risk of recurrence, is if we are able to remove as much tumor as possible, and really technically to not leave any visible tumor behind.
Yeah, I don't disagree with that at all. I think the other correlate is, of course, stage.
Right.
If you're stage 4, you're stage
That's
4.
the main, yes, yeah.
And that's just like a
course.
thing. And so if you catch these early, and that's the point of the benefit of screening, of course, screening you want to prevent before it becomes a cancer. That's kind of true screening. I guess it's still beneficial if you find it earlier, because you certainly have a far less chance of recurrence if you get it at stage 1 or 2 than at stage 3 or 4. But there's a lot of questions as to whether or not these ever progress through a stage 1. There's just so little known about the natural history of these tumors that's inside of us.
Yeah.
Other than it probably starts in the fallopian tube. So yeah, I think that that's the main predictor of recurrence is stage and residual disease. And then there's minor contributors. I think age, for whatever reason, older patients, not 65, that's not old. Older patients who develop ovarian cancer, it's different, can be a different disease. For whatever reason, it's just a little more recalcitrant. Not all the time, but it's associated with it. And then the different histologies, we always are talking about high-grade serous. It is the most common subtype, so that's what we're dealing with. And that one does tend to be pretty chemosensitive in the front line, but not always. And high-grade endometrioid about the same, but like clear cell cancers are rare. They're real difficult. We're very frustrated by their lack of response to chemo. And so getting it all out at surgery, sometimes our best opportunity to prolong time to recurrence, but they come back. Mucinous, very rare, but very much will come back and very frustratingly hard to treat. Low grade's a completely different cancer. You should just separate it, call it something different. So those are sort of I think those are sort of the main things associated with recurrence. We're learning more about the molecular markers. Of course, BRCA associated cancers overall do better to chemo, and then they respond to PARPs. I think we'll talk about that later. When we saw data at ESMO on Friday with some overall survival from 2 of our big trials in BRCA, that was incredibly promising. For the first time, we're talking about cure in a larger fraction of our patients, which is exciting, but not all. Probably not even half, but at least more than 10%, which was our old rate. So molecular markers are definitely a part of the story. And things we don't know yet, I think are really still out there.
So hopefully we'll get to that a little bit with some of the molecular markers, with some, like, for instance, like clear cell cancers and things like that, when we're talking about rare tumors. But to your point also about like the histologies, Katie, the clear cell cancers also can be diagnosed at an earlier stage, perhaps because of the association with endometriosis, which is why, cluing into some of the signs and symptoms of endometriosis may lead to earlier detection or of a clear cell cancer, for instance. So being aware
that's true
of
of
those
mucinous
symptoms
too. When you look at the ones we do find at stage 1, they're like a third, right, of high-grade serous, clear cell, and mucinous. So they tend to make big masses sometimes that come to clinical discovery a lot earlier than high-grade serous, which kind of spreckles around before you figure it out. So you're right, we do find more of those at stage 1, but they're still just they're frustratingly resistant to my interventions.
Yeah, but if we are able to detect a stage 1A that has no surface involvement or anything like that, I think even with some of the rarer types, the prognosis is so much better.
Oh yeah.
To your point about stage and that surgery alone is practically curative in those cases. But again, the problem is, we can't, if we could identify those early stage tumors and all these different subtypes, we would have a cure rate or an overall survival rate of greater than 90%. But such a small number of our patients are presenting with early stage disease. That's one of the main problems.
Exactly.
Very true. One question that came up was whether neoadjuvant chemotherapy before surgery is better than doing surgery up front. This is an area that's been studied pretty significantly in multiple prospective trials. Do you all want to comment on how you kind of approach the use of neoadjuvant chemotherapy versus primary debulking surgery followed by adjuvant chemo?
I can start. So I think this is so controversial. As you said, there have been a number of trials trying to prove the biases that surgery first is better. And all those trials thus far have not confirmed that, but they all were very biased in certain ways. So you kind of pick it apart. So there's one study that's done and maturing called the US Trust study that controlled for a lot of the limitations in those prior trials. And that is actually an incredibly important trial, one way or the other. It's either going to put to rest that there's any controversy, or people that are not really good surgeons need to start referring their patients to surgery centers of excellence. I mean, I think that's just going to be we say in Oklahoma, the come to Jesus. Like, you're going to have to accept either stop doing the 8-hour surgeries with all the morbidity, or if you can't do that, and you don't have the partners at your site to do that, they're going to have to go to a center of excellence to get the standard of care. So a lot of people's cheese is going to get moved, I think, by that study, one way or the other. So it's incredibly important for that reason. And I don't really know how it's going to play out, but I'm very interested in it because it's a really critical question that we just have to know. And so I'm really proud that it was, it's led by our good friends at Memorial Sloan Kettering and our European colleagues, and I'm very proud that they got it done. That being said, until that study results, my personal bias is for primary cytoreduction. That's just how I was trained. And my partners are great surgeons. I mainly do chemotherapy now, just how my career has gone. So if I see a new patient, my partners are going to operate because they deserve a high volume surgeon. Ovarian cancer is not, Dr. Khabele just said that. It's not easy. You got to be prepared to do all the things. And so if you're not a high volume surgeon, some high volume surgeon needs to be taking care of those patients. And that's what happens at my site. And then I get them back for chemo and I'm fine with that. It's a team. And so I feel pretty strongly about that issue. Now, if it comes to pass that neoadjuvant's fine for everybody, then, interval surgeries, although they sometimes can be really hard. So you still have to be ready. You still have to be a pretty high volume surgeon. Those are not chip shots the majority of the time in my experience, but it may just be a different world. So that's sort of how I look at it.
Well, around the country, I think people have taken it sort of an intermediate approach to this. And, the centers I've worked, including at WashU, is we use a combination of imaging and laparoscopy to sort of guide us as to whether a patient's a candidate for primary cytoreductive surgery versus neoadjuvant. And then we take into consideration a lot of other things, including the patient's frailty, patient's underlying medical conditions, and all this is sort of put into kind of a decision-making tree. Clearly, this is something that is very center dependent, and it is really dependent on what we're doing in each of our individual conversations with our patients. And we're certainly awaiting the results of this trial because I think it'll be very important. But the current data we have shows that neoadjuvant chemotherapy is a part of our toolbox for treating ovarian cancer. And so, I think that if we can perform primary cytoreductive surgery, we go for it. If we don't feel like we can remove all visible disease, then we would rather give neoadjuvant chemotherapy in our center.
Yeah, that's 100% agree. I think that the study that will tell us the decision for whether or not you go shouldn't be dependent on the surgeon's expertise.
Oh,
if
absolutely.
This disease is resectable. It
Then
needs to be resected.
Yeah.
Unless it comes with some just tremendous morbidity, right? That's different. But I think that's where the trust study really may ruffle some feathers if it's positive, because that study required you to hand in you had to confirm that you actually were a high volume surgeon. You couldn't come on the study if you weren't a high volume, radical ability to do bowel resections and splenectomies and diaphragm resections. If you couldn't validate that in your case list, that you couldn't participate in the study. So it did control for a lot of factors. And I'm very interested to see the results of that one way or the other. I'm not predicting it, but one way or the other, I'm really interested in it. The other thing I've been thinking about, and I just want to caution people, this is just me thinking, which sometimes can be dangerous, but for patients who have BRCA, for example, the neoadjuvant question concerns me a little bit more there, because I'm just wondering if you have BRCA and you already have these tumors that have such genomic instability, and then you expose them to chemo when they have so much volume of tumor.
Mm-hmm.
I'm just wondering if that is a mechanism by which we're having early reversions. And these patients
about reversion, BRCA mutations.
Yeah, BRCA reversions, and then they're very resistant, or they recur a lot earlier than patients who undergo a primary cytoreduction. So you're just down to microscopic disease. There's always tumor left, even if you think you got it all out. Right. But there's not very much. And so you're giving the chemo there, and there's a lot less to push the reversion mutations. I was talking about this at ESMO with a really esteemed colleague. And I thought that was a really brilliant suggestion. And so I'm interested to see if we can get some of that data out of these studies that have been performed, and try and figure out if that's real, because that makes sense to me. And I've actually seen patients with BRCA2 who should be, I mean, those patients should do incredibly well, who had terrible disease on presentation and really legit needed neoadjuvant. It wasn't a softball call, but they recurred very fast. And so I'm wondering what happened there. And if that's something we should take into account also when we're deciding on the timing of surgery. So I'm interested in trying to study that moving forward. So it may even get more complicated how we make these decisions if that is a possibility. But we don't have any data on that.
So what I think we're hearing though, and what we're dealing with is the need to really personalize even more our treatments and individualize our treatment for patients, right? So it's not just the molecular aspects of what the tumor looks like, what kind of mutations the tumors have, or germline mutations a patient carries. But I think that that it's really important to personalize to what the patient's desires are and what their underlying other comorbidities and goals of care are. And I think that that's something when we're talking about personalizing treatment, I think it's important to include not just the molecular features, but also, just the whole picture, because as you said, these surgeries can be really, really morbid.
Yep.
Patients can spend a lot of time in the ICU. Patients can have a long time recovering, and then sometimes it's a delay to get them to their chemotherapy if they are going through rehab and haven't recovered or bounced back from this major surgery. So I think that all of these things are so complex and require experts like you and Dr. Yamada to kind of sort this out, interpret it for the patient, for the person to then have an informed sense of what they're about to go through in their treatment course.
That's a really good point, Dr. Khabele. I think the other area that I found to be really encouraging is just the number of groups that are looking at frailty and ways to address frailty in a prospective way for patients that are undergoing debulking surgeries. So I think the Mayo Group has done a really great job with this. There are programs that kind of incorporate prehabilitation and a
prehab,
more, prehab and a more algorithmic look at frailty indices in terms of predicting outcomes and how we can kind of optimize outcomes for patients. So that's another, I think, really encouraging area around surgical treatment. This kind of segues to your point, Dr. Moore, about just the changes that might occur with treatment. I think that kind of dovetails into one question that came up, which was whether we should be doing somatic tumor testing at different points in time in a patient's treatment course, which I think is an interesting question. How many times should you get tumor testing results? Should it be at each different progression in therapy? Are there recommendations that you have for your patients, or is there an ideal state that you would like to see?
Well, I think that personally, I think everyone deserves somatic testing. I tend to do it at frontline because I do like to know the homologous recombination deficiency status, even though there's lots of limitations to that test. It is the best test we have right now. Better tests will come because it just helps me sort of plan therapy, and we can talk about that. And then I like to know what else is there, because, I think you don't find things very often. You'll find BRCA, germline, you'll find another 7% in the tumor-ish in high-grade serous, and that's incredibly important to know. You'll find RAD51C, and you may find a smattering of these other genes that we're not quite sure what to make of them yet, other than you want to make sure they don't correlate with the germline finding. But in terms of their predictability of whether or not you'll respond to PARP or other sorts of things, they're far less clear. We have to say that. But I like to know that they're there because sometimes they're actionable. And then every once in a while you find something else that's very interesting. And, I think it's just always looking for the needle in the haystack because that's how you help people. So I always look for ERBB2 amplifications because those are actionable. and I want to know about them. I like to send next-gen sequencing. I also like to get immunohistochemistry. So there's a couple assays out there. I don't want to mention them, so it's not like I'm giving a promotional talk, but I like to get the IHC as well, because we now have actionable drugs for the recurrent setting there as well. And the things that I've known thus far, like so ERBB2 is HER2, just like in breast cancer for the audience. That can change over time in patients with breast cancer. We don't know in ovary cancer sort of what happens. So, and we don't even, and it's been like that particular drug or that particular marker, for example, we've really never looked for it in ovary because the likelihood of finding it at levels that were previously termed positive is like almost never. But now there's drugs that are very effective for just a little bit of expression. And so I've started testing everyone for it because I want to know, and I'm finding them here and there. So I'm not sure about that one, whether or not I would do another biopsy later or not. We don't have any evidence that I need to do that. And I hate to put someone through a biopsy unnecessarily, but that I'm thinking about that one. Other sorts of markers that we look for, like the one that is most proximal to being relevant to clinical care is the drug mirvetuximab. And you'll know the commercial name soon. It's before the FDA, we should hear any day. That's folate receptor alpha expression. And that's for patients with recurrent disease, which we'll talk about in a moment. But we know, because we've done the studies, that you can look at the old tissue, you can look at the archival tissue, like from the first surgery, and that correlates out, many lines of therapy later. So we don't need to repeat biopsy for that, unless you don't have tissue to test and you have to biopsy, is one example. BRCA can change. We just talked about reversion mutations, but you don't pick it up by like testing necessarily the tissue. The mutation will still be there in the tissue, but it's reverted in another way. So I'm not sure if that helps us pick up like once we commercialize the ability to pick up reversions, and maybe Dr. Khabele knows this a little bit more than I do, we can't test for that yet commercially. It's only available on a research test. But once that's available, depending on how I have to test for it, tumor or blood, I'm definitely going to be sending that test, because that will totally change how I sequence their subsequent therapies. But right now, I don't think there's any reason to do repeat biopsies. There has never been an actionable change. There are changes that are kind of interesting to look at. The tumor microenvironment changes, a lot of things change, but it's not been actionable. Like, it doesn't change how we treat you. So, I wouldn't repeat test.
I would say that a little caveat to that, as a translational researcher with a lab, I think in the context of a clinical trial, it's a different story.
Oh, 100%.
So I think that I totally agree with you. Just in general clinical practice, we're not testing every time there's a recurrence. But I would say that it's really important if people are willing to do it. And I know, again, it is hard to get actual tissue biopsies. Interventional radiology or going back to the operating room can have some risks associated with it. But as we're developing new markers, as we're looking for new markers, there's the possibility of a liquid biopsy, right, that we can hopefully monitor at different points of treatment and perhaps at the time of recurrence within the context of a clinical trial, that we can then correlate or match with whatever we're getting from the tissue to make sure that we're accurately seeing these molecular changes and trying to decide if something in the future could be actionable. So I think within the context of a very well-designed clinical trial, multiple biopsies are helpful. I don't think they should be mandatory, but if people are willing to participate in a clinical trial where they are willing to provide biopsy tissue, I think that would be helpful. The reversion mutation for BRCA, I think that if we could, and it's getting closer in a variety of ways to be more of a liquid biopsy, I think that's very promising.
Yeah. We need
Great.
that test right now. This is right now.
Fun, more research.
Yeah, and more research.
Yes. So moving on to the next topic area, which is maintenance therapy, which is a really exciting area with a lot of new data coming out, including what you just talked about, Dr. Moore, the update from ESMO. There were a number of questions around PARP inhibitor maintenance therapy and bevacizumab maintenance therapy, but just to make sure that everybody's on the same page, can you all just kind of describe the hereditary testing and genetic testing that you do in patients that are initially diagnosed, so that we can then kind of talk and dive a little bit deeper into some of the maintenance therapy questions?
Go ahead.
Well, I mean, if a patient has epithelial ovarian cancer, the recommendation is to perform genetic testing to determine if they have any sort of BRCA mutation or alteration in a pathway called homologous recombination. And that is a pathway, a protein pathway that repairs DNA damage. So if a person has hereditary ovarian or breast cancer, the most common genes that are altered are BRCA1 and BRCA2. So the very thing that predisposes the person to developing ovarian cancer may in fact be an alteration that makes them more susceptible to, or their tumors more responsive to drugs like platinum and the PARP inhibitors. So it's really important to get that testing done early. As Dr. Moore was saying, she tests everybody on diagnosis and sends somatic testing or molecular profiling of the actual tumor in case there are alterations, somatic alterations, meaning alterations in the tumor or the tissue itself. And so that helps us kind of determine that those tumors that have BRCA mutations are actually going to be quite responsive to the maintenance therapy with PARP inhibitors as single agents. And so that's been really a game changer and a huge advance in the treatment of even advanced stage 3 and 4 after, primary treatment, first line treatment, followed by maintenance therapy. And so that's just the big picture. Dr. Moore has the more specific and very exciting, hot off the press from the European meeting, right?
Yeah, so we have had, I was trying to pull the slides up. We've had approvals for use of PARP inhibitors following frontline therapies for BRCA-associated cancers, really since 2018. And then in 2020, the non-BRCA cancers were approved as well with niraparib and then olaparib, bevacizumab. So they've not been around for very long, the approvals, but the trials have been around for a bit. And so we have long-term follow-up. So we presented, Dr. Paul DiSilvestro, my co-PI, presented 7-year follow-up on SOLO-1, 7 years. I mean, that's a long time. And the results are just phenomenal, not just in the percentage of patients who are still alive, which is a lot. Even patients who are randomized in the front line to receive placebo, many of them very appropriately receive PARP inhibitors in later lines of therapy, but half of them are still alive at 7 years. It's almost 70% of patients, 67% who received olaparib. So I think one message is that I think this shows us you can't catch people up. So you should not withhold PARP in the front line. I've heard people say this all the time. They're going to wait and see if they recur and then don't do that. You don't catch someone up by using a PARP in the second line. You don't catch back up. It's frontline. It's a frontline opportunity, period. But the more important, so that's exciting. But the more exciting thing to me is that when we look at the update of really progression-free survival, which is the time from starting the PARP inhibitor. So they finished chemo, so 6 months. Then they went on the study. So from that point until progression, or the last time point, that's progression-free survival. That's what we mean by that. And so for women that were randomized to olaparib on that study, about 50%, a little less than 50%, have not recurred at 7 years. So they have been off their therapy for 5 years on nothing, living their life, which is just
Remarkable. I
phenomenal.
mean,
We've never seen that.
yeah.
And it's not true in the placebo arm. You know, we don't see the same thing. So there is a group of patients who need nothing. I fully believe that. And if I could tell who they were, I would not give them anything. I would leave them alone and let them be cured from the get-go. But most patients are not. And so, but we have a little less than 50% without any recurrence at 7 years. And the kind of slope of the survival curve is very, it's very shallow. It's very horizontal. So very few patients are recurring, you know, over time. And so you kind of are in a point almost, not quite, where patients we're kind of in the general population survival. Like patients are going to die of other things because, you know, they're 75 or 80 or whatever. It's been for some of them 9 years since they were in the study. Those that went on earlier, and we get older and we die, but they don't die of ovary cancer necessarily. So we may never reach what we call the median overall survival, which is the end point of a study when half the patients have died. We may never hit it. So awesome. And then the other long-term, well, it wasn't as long because the study's younger. It's called Paula, which is the study of olaparib and bevacizumab, or you all may know it as Avastin, where they combine the two. Funny study, wouldn't design it this way today, but you know, we always can criticize things in the past. It's called being armchair quarterback. But they compared the combination of a PARP, olaparib plus Avastin to just Avastin, not to monotherapy PARP. And so that's the missing arm. And that's where sometimes there's confusion about whether or not you need both. Is it better, or is it just more stuff? But so that remains true. We don't have that answer, but they presented 5-year data for BRCA and also for non-BRCA, what we call wild type, but they have that homologous recombination deficiency marker, that group. And they did remarkably well out to 5 years. And we have a large number of patients that have not recurred. So, so that's exciting too, because you're seeing the benefit extend now beyond BRCA, because that's what really, I mean, that's what we're interested in. I'm excited to have, we'll talk about this either in this section or the next section. There's so many things in the recurrent setting that are exciting, that I'm excited to have for my patients, because they're going to prolong their life, and I can sort of quilt together these increments of progression-free survival and prolong overall survival. I'm excited about that. But ultimately, I would rather you not be my patient on therapy for 8 years. I'd rather you just get 2 years of whatever and then be fine. And so, you know, that's the goal is, you know, can we increase by whatever means possible, PARPs plus Bev, optimizing surgery, that combination, how many more, what percentage more can we just be fine after 2 years, and they don't need all the things we're developing because they're cured.
Well, Dr. Moore, I've had patients ask me why they need the chemotherapy. Why not just give them the PARP inhibitor? And, you know, I think that's becoming a question that people who don't do GYN oncology have been asking. I think it's a very reasonable question. But what I do explain is that, you know, our platinum-based frontline therapy, after, you know, cytoreductive surgery that's been very successful, has outstanding response rates initially. So the bar is really quite high if you're trying to do a comparative, and that may be really hard to do in the setting of a clinical trial. And so that's why it hasn't been done. But do you get those questions as well?
I haven't really had somebody ask me, because a lot of the time, you know, I don't know someone's germline status when I'm ready to start the chemo, because we're still sending it off and we've already started the chemotherapy. So I haven't had as much of that, but I will say, you know, all of our good friend, the brilliant Dr. Shannon Weston at MD Anderson has a trial running for women with BRCA associated cancers that are going to get neoadjuvant chemo, and instead they get neoadjuvant olaparib, and then they go to surgery. And so that study is accruing. There are absolutely patients that want that approach and are willing to be on a clinical trial. I would not ever say we should do it off of a clinical trial, would not be supportive of that, but it is being studied. And I think to my earlier kind of, you know, I have a question comment about whether or not we're inducing reversion, she's going to have tissue from the time of surgery and blood. And so she's gonna be able to look at all of that.
Right.
And so maybe it is a great idea in a certain population, but there is a small trial running now. It's first of its kind to assess that in a biomarker selected group. But I think we really have to let her run that before we
Right.
try to be early adopters.
Well, I think we're going to wrap up the first session at this point, but please plan to come back for the second session. We're looking forward to it.